Hi guys, so you might be wondering why is there a whole nother video attached to this mess that you've already been sitting through? Well, the truth of the matter is when I was making the presentation, I recorded more strip interpretations than I needed. So rather than let that go to waste, I've created this practice strips video instead. So these aren't necessary in order to complete basic arrhythmia or advanced arrhythmia, but it does give you the opportunity to maybe look a little bit deeper or find some additional guidance on strips that maybe give you trouble. So A flutter is a good one. How to count the P waves and the conduction ratios with that. Or third degrees. I know I've got a little bit of extra there and some pacemakers. So just feel free, go through this section on your own if you want to. If there's things there that you find helpful, outstanding. If it's something you don't feel you need, not going to make you do it either. Thanks again for watching. Okay, just looking at the strip, you can tell immediately that this is wildly irregular. So let's go ahead and count them out. So we've got 12 beats, so 12 times 10 gives us a rate of 120, and so we're tachycardic. We don't really have a pattern. And you could argue that maybe number 7 is ectopic because it's so early, but this whole mess is so irregular it's kind of hard to say which one's inappropriate. So we'll just go ahead and say no ectopics for now. Question number 7. Taking a look at the P waves, we've got that same thing going on again. There are many types, and it is irregular. But we do have 1 P for every QRS, so we do have that going for us. And let's go ahead and name them just like we had before. The easiest one to identify is probably going to be starting with wave number 2. Because that one's got a nice peak to it, so we'll call that one A. And who's got the next most similar? I think number 6 has a pretty sharp point to it. You could maybe argue number 8, but it's a different shape. Number 10, though, I feel like has a very similar shape to it. Now, if we look at beat number 1, that's got a bit of a peak to it, but it's more rounded by comparison, so we'll call that one B. Actually, number 3 matches that pretty well. Number 5 does a really good job. And we'll go 9 and 11 as well. I think all pretty well match that, just in the way they look. So the next question is, do I have a C? Well, there's at least one of them that has, actually if you look at number 4 and number 8, they're pretty similar, so we could probably argue that those might be C, or they could just be derivations of something else, so they're a little bit questionable. But definitely number 7 has its own version as well. So if we go A, B, C, D, so we'll say A has a peak to it. We'll say that B is a little bit more rounded. We will say that C is sharp, and that D is got a dome, we'll call it that. But again, it's 1 P for every QRS, highly irregular. Those are our P waves. So let's see what we get. So let's measure out the A's. And this will be pretty convenient because we can measure starting here. And I'm going to say this guy actually starts when the wave shifts shape. So I'm actually going to go out here. Say that that's 1, 2, 3. And so I've got about a 3 for that one. Now, what do we got next? doesn't look to be much difference. 1, 2.5 or so. We'll check another beat just to be sure. Let's say it started about there. It's 1, 2, 3-ish. So it's probably closer to 3, is what we'll call that. And so if we want to measure C, a little bit more difficult to tell where things really change at for him. It could be this wide or it could be a little bit more narrow. Kind of hard to tell. But this one here, that little change in deflection right there gives me the 1, 2, 3. So 3, 3, 3. Last but not least, we'll measure D, which doesn't even have a PRI, which is kind of weird. None of these have a PRI, which makes it kind of odd. But still, it's that different conformation, repeating pattern, leads us to look towards something else. And so I'm going to make that one actually a 1, 2.5. So that one, sorry, times 0.04, 2. Which is actually short, so that's something to be a little concerned about. But if you think about, again, multifocal atrial tachycardia, these beats can come from anywhere. So this one may have actually originated right next to the AV node and significantly shortened the AV node's ability to cause a delay before it's conducted through. Last but not least, we'll talk about our QRS, and those are all pretty well identical. They're quite uniform. The only one that's out of whack, I'm going to say, is probably number 7, because that has a wider QRS just by eyeballing it, and number 9. Those both have slightly wider QRSs compared to the rest in terms of shape. But if we go ahead and measure these out, let's just go ahead and measure number 10. And so they're essentially uniform. They have a small QR pattern, and it's right at 1.5. And so that is normal. If we measure number 7, it's a 2. So 2 times 0.04 equals 8. And then same with number 9. And those are normal. So that could just be a case of aberrant conduction that's going on there. At the end of the day, though, we've met all the criteria of tachycardic, irregular, unique P waves, which all have their own their own PRIs, which are essentially within normal limits. I'm still kind of concerned about D. But the QRSs are all essentially normal. So that is Matt. Okay, go over our basics. It is a 6-second strip. Okay. So we have a heart rate of about 80. And how to get that? Of course, it was 8 times 10. It's irregular for sure. There's no pattern to that irregularity. And it is beat number 7 that is ectopic. So what do we know about the P waves? So for our native, I've got upright, uniform, and they are regular. I've got 1 P for every QRS. For my ectopic, I have an inverted P wave. So let's take a look at our PRIs. And so with our native, let's go ahead and do beat number 5 here, because that P wave starts on a Q, or starts on a line. That one ends there. So that is 4 small boxes. And since that pretty much started there, we'll say it, and the QRS ends here. We'll say that that one's 2. We'll come back to that in a second. As for our ectopic beats, this starts just a little bit after the line, and it ends rather abruptly right there. So that's only about 2 small boxes. That is well under the 0.12 that a normal QRS would be, whereas these are normal. All right. So now we'll just take a look at our QRSs, and we'll say native, uniform. We have a QRS pattern, and I measured it out to be 2 before. So 0.08 seconds, that's normal. And for our ectopic, and we will say from here to here, 1, 2. So that is also so both of those are normal. So since we have an inverted P wave with a short PRI, less than 0.12, but the QRS is normal, and of course everything else is essentially normal, you have sinus rhythm with PJC. All right, on to the next. We'll do our usual. And we are 6 total beats. And we can actually count between these as well because we are very regular. We have no pattern. And no ectopics. So what is our true measurement? Well, between here and here, I get a total of 25 small boxes. By golly, that is normal. So we have a normal rate, we're regular. What do our P waves look like? Well, they are in fact inverted. Inverted before the QRS. Now, they are uniform. I have one P for every QRS, and they're regular, as in they're happening regularly. So can I measure a PRI with this? Well, let's take a close look, shall we? And we have this one starting just about on a solid line, and then this one ending right about here. So I've got 1, 2.5. We'll check another one just to be safe. .5. So 2.5 times 0.04 equals 0.10, which is shorter than our normally expected 0.12. Correct. Lastly, the QRS, they are uniform. They have QRS pattern. And if we measure these guys out, I'm going to say, let's go with this one here. Starts about halfway through, ends about halfway through. 1, 2. So we have a normal rate, we have regular, we have a inverted P, and we have short PRI. Oh, and normal QRS. That is accelerated junctional. Okay, just a couple more SVT rhythms for the accelerated arrhythmias class, just to give you a little bit more practice, because these can be tricky. We'll go ahead and get this marked out. Of course, it's a 6-second strip, as always. Now, if you look at it, you can probably tell already that there's some irregularities and that it's pretty darn fast. Sorry, my 16 was off there a little bit. So we're definitely tachy. Sorry, that is a 7. And we are irregular. And it doesn't really seem to be due to ectopic beats, right? Because the QRSs are pretty much identical. But do we have a pattern? And if anything, I'm going to say that it is regularly irregular, but that it doesn't really have a pattern to speak of. So we figured that out. In terms of P waves, do we have any? I'm going to say no P waves. But if you look closely, here, here, and here, you see something that may be reminiscent of a P wave, but more importantly, if you look right here in front of beat number 5, you'll see it just kind of waves a little bit. There's just kind of some undulation. And so in looking at how irregular it is and the fact that there's nothing that really consistently looks like a P wave, I'm going to stick with saying that there's none that we can reliably say are P waves that are responsible for generating these QRSs. And so to that point, we have no PRI. The QRSs are, of course, uniform they have in our, actually we have a few different patterns. By and large, it looks like we have a small QRS pattern most of the time, with some variations here and there. The T waves all look pretty well uniform. They're just peaked a little bit, which is a sign of a few other different problems, but that's for another part of the lecture. Ultimately, we will measure these out, and I'm going to say with beat number 7 is a pretty good one to measure off of. Probably about 2.5. I guess about 10, which is normal, or narrow, which is more of what we're looking for. And so if you take the tachy regularly irregular, no good P's, and you can argue if those were maybe F waves here on beat number 5, and normal QRS. I'm going to call that AFib with RVR. Now, at first glance, if you're just looking at the patient and you want to go, you know what, that's a heart rate in the 170s, they look like crap, that's an SVT. But again, the most important part of what we just said is that you checked the patient. You have to check the patient when their heart rates are fast like this. It's the most important step of any of this interpretation, is putting your eyes on the patient when it pops up. That's going to drive your treatment. Then when you sit down and you look at it later, you can figure out if it was AFib or SVT. And again, when you check on the patient, the most important things you're going to look at is how to treat them. And so it's following ACLS, right? If they're stable, meds. If they're unstable, you're doing synchronized cardioversion. Those are your go-to. Those are the recommendations right now. Again, a strip from the basic arrhythmia section with all the markings done to look at and figure out what the escape rhythm is in this scenario. We know a few things. We know that we are bradycardic with a rate in the 40s. We're completely certain that it's third-degree block. And what we have is almost a borderline QRS, the fact that it's right at 0.12. Now this was a tricky one to measure because, and I'll just draw back over it again, actually I'll just draw it in a different one. On beat number 3, you'll see how the QRS starts pretty cleanly right here. It goes up, it comes down to a sharp point, and then kind of slurs its way up into the T wave. So I don't know where the S wave ends and the T wave begins because I don't have an ST segment. All I can do is go off the J point, which is the very tip of the S wave, which happens about right here. And that leaves me with exactly 3 small boxes, which is 0.12, which is normal, which at that point technically makes it narrow. I'll also note that the T waves are upright, or that their deflection is the same as the R wave, if you want to think about it that way. Those two things right there really are what support, in addition to that rate of 40, supports junctional escape. Now, I could easily see how someone might look at that, just eyeball it and say, oh, that's a wide complex, and it's a 3rd degree, so that must be a ventricular escape, and they dive right in. I could see where you get that, and I wouldn't be able to stop you. because at the end of the day, I'm going to intervene doing ACLS protocol for bradycardia. Whether it's wide complex or narrow complex, slow heart rate doesn't really change much for us. We can still try atropine, it won't work. Then you can go ahead and put the pads on them in the meantime, because that's really what you're going to need to do. Dopamine might make a bit of a difference, because if it's junctional, the dopamine should help. But either way, I'm going to go ahead and say this is third degree AVB with junctional escape. Building upon another strip, this is third degree heart block. What do we know about it? Well, we know that this one is bradycardic. We know that we meet all the criteria for third degree. We have a QRS that is 12, but that's still normal, which makes it narrow. And even if you just step back and look at it, you can tell that those are really sharp spikes. They're tight together. That should be enough right there to let you know that this is junctional escape. You may be wondering why now this is like the third or fourth one in a row that has junctional escape is the answer. Well, the truth of the matter is that is the more likely scenario of you actually seeing one of these patients live long enough to make it into your hospital. If you're going to see an a ventricular escape, either they're really, really lucky, or they've wound up evolving in front of you and watching that heart actually get worse to the point where it's a ventricular escape instead. But yeah, between the narrow and the rate fits, this is third degree AVB with junctional escape. It may feel like I'm really starting to overdo these at a certain point, but I want to make sure we have plenty of practice, because this finding third degree heart block really uses every one of the skills that you learn along the way as part of basic and advanced arrhythmia. But I promise we're almost done. Gives you 40. We are regular. It's a no pattern. Now, ectopy. I have more P's than I do QRS. Let's go ahead and mark out those P waves that we can see. Well, that certainly looks as irregular as heck, but if you step back, like really lean away from the screen and just look at this, compare all of those QRSs together, particularly their T waves, and you'll notice that we have different types of T waves. If you look at beat number 2 and beat number 4, you'll notice how the T wave goes up, comes down, goes up again. Now, if you look at the position of the other P waves, that might explain why it does that. So let's do some cool stuff. We're going to go ahead and we'll measure out the ventricular rate because we are regular. And then we'll come back to our P waves. So the ventricular rates we'll just measure between the first and second beat, and that is from here to here. And that comes out to about 42. And that gives us, oh, sorry, I wrote that in backwards. Apologies. .36, which gives us a heart rate of 42. in terms of our P wave measurements, the only two clean P waves that I have to measure between is actually this one right here, between beat 3 and 4. So we'll measure between these two, and we get the number 14. So now if I measure backwards by 14, I should have a P wave hiding right here. And if I measure forward 14, that's the start of this one. So that's a P wave. And so I can actually mark this out, because if I go another 14 this way, sure enough, that's that P wave. If I go another 14, and then that's that P wave. And if I measured back again, there's that one. So I actually found 4 hidden P waves in this case, or on this particular rhythm. So we're upright, we're uniform. I have more P's than I do QRS's. They are regular for sure. I've got 4 hidden. So we're definitely dealing with the block. We'll do the PRI measurements. That first one comes out to about 3. Our second one, which actually we'll just take from here to here, and that gives us 10. From here to here, on beat number 4, that's 3.5. So I've got 3, 10, and 3.5. There was no reset because we've had multiple beats drop. In fact, I would almost say that this was a 2-to-1 if it wasn't for the fact that those P waves are being hidden in a irregular fashion underneath those QRSs, or underneath those T waves. And so because of that variability in the PRI, it can't be a second degree type 2 of in any way, shape, or form. And so we will just say wildly inconsistent. No pattern, no reset. Third degree. Our QRSs, however, are uniform. They're uniform. It looks like we just have an RS pattern for those. In terms of measuring the QRS, this is a little bit challenging, but we're going to have to go again with those rules about using the tip of the S wave as our J point. I'll actually use the very first one as our point of reference. I'll even measure this one a little wide, and I still get 2.5. See if you guys get something different, but 2.5 times 0.04, which is normal, and that is narrow. Even though there's that wide slur that occurs, that has more to do with the heart having difficulty repolarizing afterwards, and things of that nature. So to that end, we've got third degree heart block, and I will, just because we've been doing this in blue, I'll reinforce it. Just that easy. So here's another example of anti-tachycardia pacing. If you just look at it from a distance, you can pretty much tell right away that this patient's in VTach, polymorphic VTach to be exact. What makes this strip important is, and if you go back to the ventricular lecture, you'll see that this is a strip that I used at that time. But you can see that there's pacemaker spikes throughout this. You can't see them in the middle because the amplitude of the waveforms are a little too high for you to see them. It kind of cancels it all out. But this patient has clearly got pacemaker spikes in addition to the ventricular tachycardia that's going on. And we're going to go through and try and suss out all the details. So rate-wise, we can tell that this guy is pretty darn regular. I mean, the amplitude changes, but the overall speed seems to be just about the same throughout. I'm going to go ahead and mark it as irregular, though. Rate-wise, let's just go ahead and measure between a couple of them. We will say from here to here is 1, 2, 3, 4, 5, 6. That comes out to about 250. And then that's for the native. As for the paste, we'll use these ones on the, we'll just stick to the left side. This one here to about this one here is 1, 2, 3, 4, 5, 6 as well. So we've got 1500 divided by 6 equals 250. And if you measure any of these throughout here, you'll see that's the same, that those pacemaker spikes are happening at a rate of 250. So it's obvious that the pacemaker is going at a very rapid rate, which is a strong indication that maybe it's trying to do anti-tachycardia pacing to get the patient out of this rhythm. We don't have a pattern. And we do have size change, which is what I mentioned when we assumed that it's polymorphic VTach. This just helps confirm and support that. I will say for the pacer, it is regular. For all those pacemaker spikes that you can see, they're all at least 6 small boxes apart, so they keep that rate of 250. It's happening fast. You could raise questions about capture because it's uncertain whether these pacemaker spikes here are actually doing anything or causing anything to change, especially when you look down here. Again, it's something you really can't confirm from this surface ECG. You probably need to interrogate to be certain. We definitely don't have any P waves, and so we definitely don't have any PRI to measure. If we look at the QRS native, we are fast, wide, we change amplitude, and that's pretty much everything you need to say that that is VTach, polymorphic. As for the paced beats, we can say that we have single spikes, but they don't equal any kind of a QRS at all that we can determine. In fact, our best guess is that it has no control or capture. Sorry. Now, where this leaves us is in a bit of a rough spot because it's impossible to differentiate the anti-tachycardia pacing from runaway pacemaker. There's a chance that something went wrong with the pacemaker setting and that's what's causing all of this to happen, whether it's pacemaker mediated or whatever you want to go with. ultimately, it comes down to kind of what we always say, which is, and I'll write this in bright red, treat the patient. You're going to be looking at the symptoms, and likely in this case, they're not going to have a pulse and all that good stuff, so need to do your ACLS, compressions, and defibrillation. Now, if this patient had an ICD, that would be really cool, because then it would do that defibrillation work for us and get them out of it. But obviously, by what you see on the screen, if it's there, it's not kicked in yet. Last little thing I'll make mention, I've made mention in the past, but I'll just go ahead and take the opportunity to give you the reminder. We know that it's VTAC, or the strong information that supports that idea is that if you look at your gauges here on the left, you can see that the amplitude of those waves far exceeds that gauge mark. So here's a real-life example of pacemaking from my collection, and we'll just go ahead and mark this like usual. So we have a heart rate of 40. But our pacer is set to that one comes out to right at about 22. Gives us 68. So we've got a pacemaker that's set for 68, but we only have 4 beats on the screen, or 40, for my heart rate that's on the screen. That right there is a huge hint that maybe we have a pacemaker firing when it shouldn't be. Regularity-wise, we're going to have to call it irregular because we have that flattened portion at the beginning. We don't have any ectopy, have any pattern. We just know that no capture on the first 2 pacer spikes. And so this right here and this right here are the pacer spikes that didn't catch. And so we have no capture. How do I know that those pacer spikes, that they are pacer spikes? Well, if you look at the subsequent beats, you can tell that that sharp depolarization right there matches exactly where the pacer marks are on the remaining beats with the strip. What I'm missing is, of course, the big QRS following it afterwards. And so that's basically how you recognize that you've got a loss of capture scenario. Not to mention, a pacemaker should fire pretty regularly, so to have that distance go without a pacemaker being there to the rescue is another great sign. P waves, native. I'm going to say we either have, I'm hesitant to call it F waves because it's just so jumbly throughout. So you could question if that's the case. But I definitely have artifact for sure. And in either case, it doesn't change much of what's going on. We just don't have any true native P waves. From a paced standpoint, we got nothing. So without that, I cannot measure a PRI. So we move to QRS, native, and we have none. There's no native QRSs, because obviously there's this huge stretch here where it could have tried and it did not. So none. from a paced standpoint, we have, so I'll just call this 1P, 2P. 1P, 2P, spike, no QRS. And then remaining beats, so 1 through 4. And we have 1 spike per QRS. They're wide, kind of tall, not really. So those are the signs that we're looking at V pacing for that. Ultimately, then what am I going to say? I'm going to say that this is V paced with loss of capture is the best way to phrase this. Or ventricular paced with loss of capture, because that's exactly what I see. Remind you what the causes of things like this can be. We can have lead fracture. We can have lead displacement. And actually, in this case, that's exactly what happened. There was a temporary pacemaker in place. The wire and patient movement caused it to float away from the right ventricle and led to this occasional capture that was going on. So this is, again, pointing out why it's so imperative that when you have temporary pacemaker patients, especially with the wire, that they hold still as much as possible, rarely any movement. In some cases, you don't even turn them. And you have to be really, really creative with how you provide cares to these patients until they can get a permanent pacemaker placed or whatever the case may be. A nice complicated one to wrap things up. As you can tell, this is a longer strip. In fact, it's 9 seconds long. And the reason why I left this strip in its the way it is so that you can really see the difference between what's happening at the beginning and the end there. But we'll approach it same way we always have. I'll go ahead and mark this out. And I did have a chance to really zoom in and count these as best I could. And that comes out to 15. That will be our native. And then if we look here at the far right side, we have these wide, complex looking ones. You know, if we measure those out and try and figure out what speed they're going, actually get a 12. That's 125. And so that's the QRSs themselves. I'll keep that marked for a reason. The pacing, however, is a bit of a different story, isn't it? If we look through, and this is part of our look at the regularity, and honestly, it's actually a very regular looking strip. It just speeds up a hair at the end, and of course the QRSs change. Wide QRS at end. If we start looking at the pacer spikes themselves, we'll notice there's a lot of problems with that. The pacer spikes, I'm just going to use arrows to point to some of them. are happening really on or after T waves in this case. And that makes things really challenging, at least at the start. You'll notice that we do have P waves pretty much always that you can see occur prior to the QRS. And so it raises the question of, does that pacer spike really have anything to do with anything whatsoever, or is it just there? And so that's where you start thinking about, is it a loss of capture? As we go forward and get to about the middle to last portion where our rhythm changes, you'll notice that those spikes are still happening, the spikes are still happening around where the T wave is at. And in fact, they start landing right, smack dab on the end of the T wave itself. And then it gets really interesting because you start seeing two spikes, one that's on the T wave and one that's associated with the QRS. And so if I saw this beat alone, I might think that the pacemaker was responsible for stimulating that QRS. However, this next beat here, this next beat here doesn't show that at all. There's no pacer spike to be seen. And that's what makes this strip, confusing and challenging is, what is the pacemaker doing? What is it responsible for in terms of, generating depolarization for these patients? Ultimately, again, that's what kind of comes back around to loss of capture, is because there's no consistency between where the pacer spike falls and then what occurs. That all being said, let's go ahead and treat this like we would with anything else. We'll look at the P wave, PRI, QRS, and all those. Okay, I just mentioned the loss of capture question spike on the T wave. So for our native, which is at the start, we actually do have a pretty good look at what's going on. So if I measure from the start here to about right there, gives me 1, 2, 3, 4, 5. I'm going to say uniform because I'm going to say that this little bit here is probably artifact. And so native, we got 5 times 0.04 equals 0.20, which is on the longer side of normal. We have, now do we have paced P waves at the beginning? I don't think so. With where that pacer spike is landing, that is really the absolute refractory period. And because of that, where that pacer spike's landing is not enough to trigger any kind of response from the heart. So I'm going to go ahead and say no on that. Which then leaves us to the QRSs. From a native standpoint, they're uniform. They have the QR shape. And to measure these guys out, that's 2 boxes. And so those are normal as well. So we definitely have a sinus tach at the start. So we know that for sure. From the pacing standpoint, we've kind of determined that the pacing at the beginning has nothing to do with much anything else that's going on. And so at that point, it's not much to be said or done about that. Towards the end here, though, it's a bit of a different matter, especially on beats like this one right here, where it looks like that pacer spike may be responsible for the QRS, but I don't see that on the other ones. In fact, really this pacing doesn't tell me much of anything. What I can do, though, is because we have 2 spikes in a row to measure, if you measure this distance from here to here, you get right at about 5. And so if we take 1500 divided by 5, that's a rate of 300, which seems absolutely ludicrous. And why a pacemaker would want to beat at that rate. And so it raises another question. Is this patient supposed to be AV paced? And for some reason, those atrial spikes aren't working. They're falling on the T waves. And so now, for whatever reason, maybe anti-tachycardia pacing popped in. And that's what it's trying to do on this latter half. Because, just looking at this wide QRS complex, if those pacemaker spikes weren't there, I'd probably be inclined to call it SVT. Because I can't see any decent P waves, that's most likely the case. I can measure these latter ones out, and I get right at 3. So they're definitely wider than we were at the beginning, but still managed to, be within normal limits there. And that just kind of leaves us with a big old question mark, doesn't it? Whether these are truly paced or not. Ultimately, it falls back to all those things that we've always said before, which is you gotta treat the patient. Treat the patient's symptoms. That's what's going to be most crucial in scenarios like this. Figure out how they're doing, what's going on. You got to treat underlying rhythm. It'll be up to the cardiologist to figure out what exactly was going on here. To figure out what exactly all this mess was. So with all of this mixed mush and that kind of stuff, I'm going to say not paced at all. We're going to say sinus tach with loss of capture, wide complex tachycardia. And that wide complex could be SVT, it could be pacemaker mediated tachycardia, things of that nature. I'm going to throw those on here real quick. Question mark. Pacemaker initiated tach. Things of those nature are what you have to consider. And that would be the final slide for that.